Okay, so when we left off on Friday, we finished up talking about our red blood cells and how they're produced and then dissolved, recycling that iron. But our big new topic for Friday was starting to talk about clotting. So we got most of our way through, but I want to make sure that we have a overview in our minds of the whole kind of progress of what's happening when we get an injury to the cardiovascular system. So like when we injure a blood vessel, when we get a cut. So what we have happening, hopefully you wrote something like this. Oh, I better use my typing tool. Okay. So we're thinking about, right, basically we're thinking about when we get a cut, right? So the first thing that happens when we get a cut, you want to know that we're exposing the subendothelial layer. So those are the pieces of the connective tissue, basically, that are lying outside of our endothelial cells, so outside of that lining of cells lining our capillary. And what's important here specifically is that there's collagen there. So we got collagen fibers. So that's what's happening when we get the cut. So our body wants to resolve this, right? Being able to see those collagen fibers basically tells the blood that we have a cut, that there's something wrong, that we need to stop bleeding. So the first thing that's going to happen is a vascular spasm. So immediately, that capillary, that blood vessel, we're going to start to have a contraction there, which is going to increase the resistance, right? Because when we decrease a radius, increases resistance, which means we lower flow to that area. And then we're going to start actually forming our platelet plug and then our clot. So the next thing we might see happen be the beginning of that platelet plug formation, which is actually the binding of something called von Willebrand's factor to the collagen. Okay. And then we're going to have the platelets first kind of sticking to that von Willebrand's factor that's bound to our collagen, which we call platelet adhesion. And then the platelets are going to lump together, right? They're secreting things that make more and more platelets stick to them. So we have platelet aggregation. Now onto our second line. Cool. So that's basically our platelet plug that we formed. The thing that's happening after we form that platelet plug is we're forming our clot. So let's say our clot begins to form. Remember that the main part of forming a clot is that we're turning fibrinogen to loose fibrin, to stable fibrin meshwork. So we talked about a lot of different things that are affecting each of these steps, but that's kind of our whole flow through this process. So we can dive a little deeper. I will scroll us through a couple more kind of review slides here on that topic before we talk about dissolving the clot. We're going to just move backwards and make sure we kind of remember where we were with clots, because this was kind of complicated. So with our clot formation, we're going from fibrinogen to fibrin in its loose form to fibrin in its stabilized form. And we're thinking about what affects each of these steps, converting that fibrinogen all the way to its stable fibrin meshwork. So we have mainly the big thing that's acting here is thrombin. So thrombin is created when we activate prothrombin. The thing that does that is something called factor X. Okay, so that converts fibrinogen to fibrin. So thrombin is directly doing that. Thrombin thrombin activates sort of another coagulation factor, I'll say, which is this factor 13, which is responsible for converting fibrin in its loose form to fibrin in its stabilized form. Now we have several things upstream of this pathway. So we have both intrinsic and extrinsic pathways that activate this factor X that's responsible for creating thrombin, that's basically responsible for regulating the creation of this fibrin meshwork. Okay. So our intrinsic pathway, we can see starts with contact with that collagen, right? We were just talking about in our big overview of the process that this is all the result of having gotten a cut that's exposing the blood to the collagen that's in our extracellular matrix, basically, right? So in that subendothelial layer, we have collagen. So contact with collagen activates a bunch of these factors, of these coagulation factors. I told you don't have to know their specific numbers because it's a little frustrating that they're not in order, right? So it's easier to think of these numbers as names. But there's a cascade, basically, so a set of dominoes where one factor activates another factor or activates another factor until we get to that factor 10. So that factor 10 is really an important one. Okay. So one thing is the intrinsic pathway, lots of coagulation factors activating each other fundamentally because they contacted collagen. So these factors are always swimming around in the blood in their inactive forms, but when they can see collagen, they start to get activated. The other thing that can activate that factor X, so that's also feeding into this process, are our tissues. So usually when we get a cut, right, it's not just damage to a blood vessel, it's also damage to tissue surrounding it, right? Because we don't usually have all our blood vessels lying directly right there on the skin, right? So tissues have tissue factors. So we have coagulation factors and we have tissue factors. Tissue factors get activated during an injury as well. And those tissue factors also activate this factor X, factor 10. Okay. Cool. So that was our clot formation that we talked about on Friday. So now, this is the slide we ended on, but really what we're getting to is dissolving this blood clot. So all these coagulation factors, these clotting factors that we've been looking at, so those numbered ones, they're coming from the liver, basically. So they're secreted into the blood in their inactive form. So they're there, they're circulating around in the plasma, they're present, but they're not forming clots until they get activated during this cascade, which gets kicked off when we have an injury that exposes the collagen. Okay. If we wanted to refer to the plasma without clotting factors, which is sometimes something that you might donate, we refer to it as serum. So serum is the plasma, so the fluid in your blood without those clotting factors included. So that's serum. We do need other substances in order to form clots, but we're not really going to focus on them, but you may talk about them in the future in your other courses. So calcium is important for factor 4. Platelet factor 3 is also important for clot formation, but I think that we have enough details to remember for a kind of basic flow for now, so I wouldn't worry about those for this class. We do want to think about factors that limit clot formation, because as we've said, like runaway clots are not good for the body, right? If you have a clot break off, for example, from the blood vessel wall, right, and then start circulating through your body, it might migrate to the brain, causing a stroke. So we don't want to have clots just forming willy-nilly. So we have these anticoagulants, right? Anti means against, coagulants we now know is that clot formation. So there are anticoagulants that are present in the plasma and on the surface of endothelial cells. Just like we had healthy endothelial cells with their platelets giving off these different substances that basically prevent platelet plugs from forming, we also have anticoagulants limiting the clot formation. So we have one tissue factor pathway inhibitor also. So we have anticoagulants in the blood. So that's one thing that's happening. Usually when we have healthy tissue, we have the endothelial cells secreting this tissue factor pathway inhibitor, which is basically just turning off that extrinsic pathway, right? I'm going to scroll back real quick to that extrinsic pathway, right? So what we're saying is that we have a tissue factor inhibitor, right? Healthy endothelial cells, so undamaged stuff, is turning this off. So basically preventing this from activating. So if we prevent this from activating, we don't activate this factor X, which means we don't eventually create this thrombin, which means we don't turn fibrinogen into fibrin. So that's how that piece is working, that tissue factor pathway inhibitor. And we also have a molecule called thrombomodulin. Thrombomodulin is also secreted by healthy endothelial cells. So you should see a pattern here, right? In both our platelet plug formation and in our blood clot formation, we have healthy cells constantly secreting these things that inhibit the formation of plugs and clots. So thrombomodulin is secreted by these healthy endothelial cells. And what it does is it basically it kind of uses up thrombin, and we want to say. So thrombomodulin binds to thrombin. So that means, and again, I'm going to scroll back up to the picture just so we can see what I'm talking about. So thrombin, we remember, right, is down here converting fibrinogen to fibrin. So what thrombomodulin does, and it's secreted by those healthy cells, is it binds to thrombin. So basically soaking up any thrombin that is circulating around. And when it binds to thrombin, that means that there isn't thrombin floating around to convert fibrinogen to fibrin. Okay. So when it binds to the thrombin, it forms a complex that activates protein C, which is an anticoagulant itself. So it's kind of a loop here. When we have this thrombomodulin binding the thrombin, it's producing more anticoagulants. So we're really limiting that clot formation. So in order to have a clot form, we have to have a lot more of these coagulation factors, these clotting factors going down those intrinsic and extrinsic pathways to kind of overcome this constant kind of tamping down from the healthy endothelial cells. Okay. So finally, we do want to dissolve blood clots. So we don't want them to just break off and still stay a clot and float around in our bloodstream. We want to fully dissolve them when we've healed, basically. And this also involves a conversion step, basically. So we have this molecule plasminogen. It gets converted to plasmin, which breaks down fibrin. So remember, our clot is just a stable fibrin meshwork. So plasmin, once we have plasmin, breaks that down. One way we can get here is through tissue plasminogen activator. So endothelial cells actually secrete tissue plasminogen activator, or TPA, during the clot formation. So this is not a case of healthy endothelial cells producing it. It's actually while the clot is forming. And basically, ultimately, it's kind of activated by fibrin, right? So these endothelial cells, as they're making fibrin, are also making this tissue plasminogen activator, this TPA, which is ultimately going to break down the fibrin. So it's kind of acting on a lag, right? So we have fibrinogen making loose fibrin, making this stable fibrin meshwork. And that pathway is moving along. But as we're creating that fibrin, we're also activating this tissue plasminogen activator, which then creates this plasminogen, which creates plasmin. And that's just kind of trailing along behind. So we're forming this clot, but we're also creating these molecules that are going to break it down. Finally, there are also clotting disorders. So this process doesn't always work perfectly. And so there are specifically genetic disorders, mainly, that prevent clotting due to absence of coagulation factors. So hemophilia is one of them. It's a genetic disorder. So there is a gene with a mutation. The mutation is specifically in a gene that creates a coagulation factor. Happens to be coagulation factor 8, which is not even on our flow chart, so don't worry about the exact role there. But it's a coagulation factor that's necessary for this cascade for clot formation and clot stabilization. So if we're missing this coagulation factor, we don't form this stable clot, which means basically that it's really difficult to heal, right? If we can't form this clot, it's really central to how we're healing from injuries. So this is why you would bleed a lot if you have hemophilia, because you can't form these clots. Similar thing happens with von Willebrand's disease. It actually affects a very similar factor. But what you would ultimately observe if you were looking at a patient and you thought, maybe they have von Willebrand's disease, what you'll see is reduced levels of von Willebrand's factor. When we have reduced levels of von Willebrand's factor, remember that's actually what kind of first sees those collagen fibers after we have an injury. So when we have these reduced levels of the von Willebrand's factor, this means we're going to have decreased platelet plug formation, which was that first step even before we get to forming a blood clot. So this would also cause basically runaway bleeding. These are both pretty serious disorders that need to be under the care and management of a doctor. Okay. Finally, vitamin K deficiencies can also cause issues with clotting. So this could be kind of a dietary thing. But basically, you need vitamin K in order to synthesize the clotting factors. So as you're making clotting factors, you need certain components. One of them is vitamin K. If you don't get enough vitamin K, you can't make coagulation factors, which means you're going to have trouble forming blood clots. Okay. Finally, aspirin. So people talk about aspirin sometimes as like a blood thinner, and you may know someone who takes aspirin if they have clotting disease or like heart problems, right? Some people take like a baby aspirin every day. So aspirin is an anticoagulant in low doses. An interesting thing is that the dosage actually matters if we're thinking about the effect of aspirin on clotting. So people are prescribed or told to take baby aspirin because at low doses, what aspirin does is it inhibits the formation of thromboxane A2, which I think, actually I pulled it forward. This is in one of your diagrams earlier on in that packet, but I just pulled it out here so that we could look at it. So thromboxane A2 is one of those secretions of our platelets as we're doing this platelet aggregation step, right? They're secreting thromboxane A2, which is basically creating positive feedback in this creation of ADP and this creation of the platelet plug. So at low doses, aspirin is going to kill this, right? Kill TXA2, which means that we're not going to have as much platelet aggregation, which means we're not going to be forming this platelet plug in the same way, which means ultimately that we're going to have less clotting. So that's low doses. So that's helpful if we're worried about someone forming too many clots. In high doses, though, aspirin has a different effect. So we're going to go back and look at that image in a second again for this high dose. But the effect of aspirin in high doses, so like if you took 2 regular aspirin, it inhibits the formation of prostacyclin. So it does, reduce fever, reduce pain, all that stuff. But in terms of clotting, it's inhibiting prostacyclin. So if we look back, prostacyclin is one of the secretions of our healthy endothelial cells that is preventing platelet aggregation. So if we stop producing as much prostacyclin, this is actually going to make us form more platelet plugs, right? Because this was part of what was stopping that platelet plug from spreading kind of out to the sides and stopping platelet plugs from forming in healthy areas. So if we take too much aspirin, this is going to have the opposite effect of what we want. Okay. So that is the end of our slides. So I do have some sample kind of essay questions to get you guys thinking and studying some of the material for our exam. I'm going to share that in the chat in a second. So I'm going to stop the share. I'll pull up the chat and I'll put the link. And I'll send you guys a key after class while we work on this. I usually come up with my own answer key. Okay. So you should see a document shared in the chat here with some questions. Does anybody know immediately from their studying over the weekend a topic that they would like to go over? Because otherwise what I'll have you do is I'll move you into some breakout rooms. You can work independently on this. Just skim through these questions, find any that look particularly hard to you and try those so that you can come back to me and we can ask questions and go over those topics. But if you already know that there's something you're confused about, we can go over that as a class first. So feel free to type that in the chat or just call out if you already know something you want to talk about. Okay. If not, I'm going to break us out and you can work on those either independently or chatting in a sort of smaller setting. And then we'll come back in maybe 10 minutes, see if there are any questions for us to go over as a group, and we'll kind of go back and forth like that. Okay. That seems good. wait till everybody's here. I will share the key with you, which is in progress, but will be finished by this afternoon. Okay, I think we're all here. So I'm typing the link to the key in the chat as well. So do try things on your own, but if you keep working on this after class while you're studying, you can check with your answers here. Just wanted to do a check-in. Does anybody have any questions yet, or things that they've suddenly realized they really want to go over as a class? Typing it in the chat or calling out is fine. No, we feel good about studying in our breakout rooms. It's going okay. No, it's not going okay. I see some heads shaking. Well, I hope it gets better. Yeah, that's why we're studying here in class.
Can you go over number 3?
Number 3, sure. Let me pull that up. Yeah, this idea of compliance, absolutely. Okay. So we looked at compliance a couple times. The first time we looked at it was when we were talking about the aorta. Okay, so basically when we're thinking about compliance, we want to just immediately kind of word associate arteries with low compliance and veins with high compliance. Okay, so compliance has to do with the relationship of volume to pressure. So what it means if something has low compliance, what we're saying is that we only need a little bit of volume. So think like low amounts of volume are going to create big changes in pressure. So just a little bit of volume creates a really big change in pressure. And that's true of our arteries, right? They have these highly elastic walls, right? They have those thick walls. We've seen them in lab. They're highly elastic. So when we put a little bit of volume in there, right, it's kind of hard for them to expand. So we see a really big change in pressure. So that's low compliance. The opposite of that is high compliance. So we think about that as our veins, right? Our veins are pretty floppy, right? They're thin-walled. So if we put that same amount of volume that we put into an artery into a vein, it's not really going to cause a change in pressure, right? The vein will just kind of get a little bigger, but we won't see a lot of pressure. That's why our veins are volume reservoirs and our arteries are pressure reservoirs when we think about them that way. The one time we want to think about lowered compliance with our veins, so this bit is a little tricky. That's why we talk about venomotor tone, right? So we talked about how changes to venomotor tone, basically due to changes in sympathetic activity. If we increase venomotor tone, so we have some smooth muscle in the veins, kind of tensing up those walls of the veins, that lowers their compliance. So they act a little bit more like an artery, right? So as you put volume in there, it is raising the pressure, which is part of why we have more blood then flow into our heart, because we've changed that pressure difference between the vein and the heart, which ultimately increases our stroke volume. So in normal states, we're thinking of veins as highly compliant and arteries as low compliance. In some situations, we do think about changes to the compliance of the veins. We don't really think about changes to compliance of arteries. So the question is specifically about arteries, but I wanted to make sure we had the kind of big picture, because I know compliance can be difficult to wrap your head around. Okay, I'm seeing a request for questions 1 and 8 as well. Let me check what those ones were.
Oh, thank you too.
The answer key only has answers to the first half right now because I am typing them in my own words while you're doing them. I like to kind of skim over what we've actually done in class for every exam, so it's not like a pre-written review sheet. I actually, yesterday went through and typed up what questions I thought would help us. And I typed out the questions, but didn't type out the answers before class. So that's why. But as you can see, I'm pretty quick. So they'll be up soon. Okay. So for question 1, so question 1 is about the pulmonary circuit and the systemic circuit. But the reason I put this question on the review is I want us to remember the importance of that equation that I wrote up a bunch of times, but I'm going to write it again on our whiteboard to emphasize that I think it's really important, y'all. Okay, so that equation of flow equal to delta P. Delta is that little triangle, so that's a difference in pressure divided by R, which in this case is our resistance. So the reason this is important to me and important for you guys to know is that now that we've done this unit, you know we've talked over and over again about different things that, for example, change this resistance, right? So understanding this equation means that if you remember what some hormone or what some neurotransmitter is doing to the radius of a vessel, but you don't immediately remember what the effect would be on flow, you can just come back to this equation and figure it out backwards. So basically, it's a little less memorizing if you know this equation. But coming to the specific question, all right, I'm pulling that up in my other screen for a second. Okay, so coming to the specific question, which is about the systemic versus a pulmonary circuit, what we're saying here is that the pulmonary circuit has a really high delta P, right? So we actually know, now that we've had our whole unit, that delta P is essentially MAP for our purposes for the systemic circuit, right? Because we know that the veins returning to the heart usually have very little pressure left in them. But when we're thinking about the pulmonary circuit, so just sending blood out to the lungs, so remember that's the purpose of basically the right side of the heart, we have a kind of different situation. So one thing we see is that, what's my eraser? I'm going to get rid of MAP because that's not our delta P anymore. MAP is specifically for the systemic circuit. We have a different pressure in the pulmonary trunk than we do in the aorta. So the aorta is MAP. So going to the lungs, we're not using that. So what I'm telling you here is that we have lowered resistance in the pulmonary circuit, but we have the same flow, right? Because all the blood has to go to the lungs as well. So maybe if we write this out, right? So flow, I'm going to do it like this just because seeing it this way is easier for me with my math mind, right? So if we're dividing by a smaller number, if that was the only change we saw, right? If you divide something by a smaller number, we'd see the flow going up, which doesn't make sense because we just have a certain amount of blood in our body. So this means that we also have lower pressure going through the lungs, which is actually important for the function of the lungs, which we'll talk about in our next unit. Just basically they're fragile though. Tissue in the lungs can get damaged. So it's good that we don't have that same pressure from the aorta blasting through our lungs. It would kind of rip through those capillaries really fast. Okay, so the purpose of this question was mainly to get to this flow equation and to be thinking about that. But we did also talk about the pulmonary and the systemic circuit as well. Okay. And I'm also seeing number 8. Okay. So number 8, I'm gonna pull up our many slides on this one. Let's see. Which week did we do this? So this is where we start thinking about those alpha and beta receptors, essentially. So we saw that the effect of norepinephrine, essentially, is to activate the alpha receptors that do, I guess it was the other week, vasoconstriction. Here we are. Okay, so we're in, let me tell you the packet we're in. The arterioles packet, that's not that helpful because it's huge. Okay, but let me share this slide with you. So we did do an example one day of doing kind of a flow chart breakdown here. But basically what we're talking about is here, right? So we're thinking about norepinephrine and epinephrine, and we're thinking about their effect. This table 11.1 is helpful, their effect on adrenergic receptors. So the different types of receptors we see in smooth muscle are alpha receptors, and we don't care for our purposes whether they're alpha 1 or alpha 2. But the other receptors we're thinking about are the beta receptors. So we can see from the table that norepinephrine really likes those alpha receptors. But epinephrine really likes the beta 2 receptors. So the effect of norepinephrine is going to be to bind to the alpha receptors and cause vasoconstriction, because that's what the alpha receptors do. The effect of epinephrine, if we have small amounts, is going to be to affect those beta 2 receptors, which will cause vasodilation in the skeletal system and in the heart. So basically skeletal muscle, sorry, not skeletal system. It's not doing stuff to your bones. So basically increasing blood flow to your muscles, to your heart. If we have it in high concentration, so as it starts to ramp up, right, like first it does vasodilation, but we can see that, I'll erase here, right? So we can see that those beta 2 receptors from that little symbol in the middle, right? There are 2 little greater than signs, right? Norepinephrine really isn't having an effect here, but we only have 1 here for alpha receptors, which means that if you have high amounts of epinephrine, they actually do bind to these alpha receptors as well. So when we're thinking about epinephrine, we want to think about the amount. And this is important because you don't want to like pass out when you go for a run as you have epinephrine acting on those beta 2 receptors, getting blood to your muscles. So it's important that you have enough epinephrine going to cause vasoconstriction everywhere else, getting to those alpha receptors, because that keeps your blood pressure up. So your brain keeps getting enough blood. So that's why we're thinking about different levels for epinephrine, but norepinephrine, we're really just thinking about vasoconstriction. Let me check the chat. Okay. Anybody have any other numbers that, oh, we're already at 12:35. That was fast, guys. Okay. So go ahead and email me questions, email your TAs questions. We can meet in the interim, but tomorrow is your replacement spring break day, and I recommend you take it and have a little bit of a break, at least during the day. But I'll make sure that those answers to the answer key are up by the end of the day. So as you skim over those, if there's something that really doesn't make sense, get in contact with me and I'll help you out. Okay, so have a great day tomorrow, everyone. Bye.
Thank you.